Okay, so surface anatomy of the knee. If we start proximal here, we have the quadriceps, comes into the superior retinaculum, so we'd have the medial retinaculum, superior or central retinaculum, and lateral retinaculum as the quads blend into the joint itself. The superior pole of the patella, the medial and lateral borders of the patella, and the inferior border of the patella. If we reach under, we can sometimes feel the facet on the medial side or the facet on the lateral side. If we go back to the inferior pole, as we trace it down, that's the patellar tendon between my fingers down here until it attaches to the tibia on the tibial tuberosity. If we go to the medial side of the joint, over here on this structure here, the medial collateral ligament will attach on the medial femoral condyle, and you can palpate that area there. It's fairly broad ligamentous attachment here, and it courses distally through this area and attaches down here on the tibial tuberosity here on the medial side of the tibia. Not really a tuberosity, but the attachment point there. The pes tendons also wrap around this area, and they ride over the top of the MCL. And oftentimes we can get fooled with patients saying that they have pain on the medial side of their knee. It's easy to go to a ligament injury, but you have to tie that into their history. Sometimes it's more of a hamstring or a soft tissue injury. And if we go lateral, we can always palpate the fibular head fairly easily right here. So the fibular collateral ligament or lateral collateral ligament attaches distally to the fibular head and then courses up to the lateral femoral condyle. And if we put the patient into a figure 4 position and kind of stress that, we can actually palpate that ligament quite easily here. We come back out and look at the joint. Natalie's joint here has no effusion, but from a surface anatomy, she had a big effusion. We typically would see that showing up in the superior pouch of the patella or in these little soft spots on either side of the patellar tendon, because they actually have the path of least resistance. The thinnest portion of the capsule is here in the back, so we can always feel or palpate the back side of the joint or the posterior part of the capsule, and usually there's some bogginess or some fullness back there if the patient has a chronic effusion. But that's the surface anatomy of the knee, so we always have to think of what these structures look like deep to the skin. So quadricep, retinaculum, bony patella, tendon, and then the ligament structures here and here. And then the joint capsule, if it's full of fluid, will show up where there really isn't a hard or solid structure like the patella or patellar tendon. So it shows up on either side or up above, or even more so here in the back.